Hello, friends. So today I'll be talking on this topic, nosocomial meningitis, challenges in diagnosis and management. So this was the talk I was meant to give in Indore in November 6th, 2022. So most of this talk will confine to meningitis secondary to any neurosurgical procedures. So we'll talk about epidemiology of the infections that prevail with various different procedures. So, wish to acknowledge my colleague, Dr. Sudhakar, who helped me develop this content. So, when you look at the nosocomial meningitis, so one of the main reason of meningitis that occur within the hospital is due to various interventions that happen to the brain. So, the commonest one that you would see is following the ventricular drain, external ventricular drain placement, or anything that leads to breach in the skull and leptomeningeal breach. So whenever there is a communication of the meninges with the surface or with any contamination, or even the breach in the blood-brain barrier. So this is the typical blood-brain barrier schematic representation. So any breach in the blood-brain barrier or any sort of an injury to the brain, any intervention to the brain, which leads to breach in these barriers, lead to occurrence of meningitis or increases the risk of meningitis. So whenever there is breach in the structurally or physiologically at blood-brain barrier. So we'll go according to the causes. So with regards to craniotomy, which is a commonest procedure done, so the risk of infection is put as 0.8 to 1.5%. And most of the studies of epidemiology of infection secondary to procedures come from USA. And most of them are published in Neurosurgery Journal. As you see, this particular data comes from France and US. So it is 0.8 to 1.5% is the risk of patient developing infection secondary to craniotomy. And 1/3 of these infections tend to occur in the first week after craniotomy surgery. And the second 1/3 happens in second week. So it's easy to remember. And the next 1/3 happens in the third week. So up to 3 weeks is the risk after craniotomy of someone developing nosocomial meningitis. And the risk is 0.8 to 1.5%. And this is very important. So in whatever we discuss about nosocomial meningitis or post-surgical meningitis, the commonest cause is, as we said, breach in the leptomeninges. And when there is a breach, so there is CSF leakage. So all these blue things that you see is where the CSF is stored. So the CSF leakage into the sinuses or into the ear or into the nasal cavity remains the commonest risk factor for someone developing meningitis. So this is something which would be repeating in any sort of a neurosurgical post-surgical meningitis. There will be some CSF leakage that happens from the dura into the sinuses or into the nasal cavity, and that remains a very important risk for meningitis. And the duration of surgery also is considered to be a risk. So any neurosurgical procedure that lasts more than 4 hours is considered as a risk factor for developing nosocomial meningitis. Then we'll move. So that's about craniotomy. We'll move to internal ventricular catheters. When we talk about internal ventricular catheters, more to do with all the VP shunts, ventriculoperitoneal shunts or any other shunts. So most of the time, the infection happens when there is colonization at the site of insertion or during insertion. Whenever there is colonization of bacteria, that remains a very important factor for developing meningitis. Or another important is frequent manipulation of these ventricular drain for any reason leads to occurrence of meningitis. And the risk for meningitis occurs in about 4 to 17%, and this comes from this study from Switzerland. So 4 to 17%. So the risk with internal ventricular catheters, VP shunt, is much higher as opposed to craniotomy. As you see, it up to 17%. And they tend to occur within 1 month. And you saw in craniotomy up to 3 weeks. So here, up to 4 weeks, there is a risk of them developing meningitis with regards to internal ventricular catheters or VP shunts. And as I said, the frequent handling of these catheters for any reason is one of the important risk factor for meningitis. And there is a very interestingly a study that has come from Canada, which shows if there are presence of any holes in the gloves. So in fact, when I saw the author, I thought this must be from India where you may have holes, but this was a study from Canada where holes in the glove, which we seldom pay attention to, and possibly we underemphasize the importance of this. They found the presence of holes in the gloves was a very important factor of someone developing meningitis in neurosurgical sort of a patients, which I found it extremely interesting. And based on this particular study, which came in 2001 by Canadian authors, so there are other studies which do indicate double gloving. Having two gloves has shown to significantly reduce the risk of these infections in neurosurgical patients, especially with the ones with VP shams. And there is even a suggestion that before handling any of these catheters, the doctor or any of the healthcare professional should double glove. And when handling the catheter, the first glove have to be removed, and then the catheter has to be handled. And this has shown to significantly reduce the risk of infections in internal ventricular catheters or shunts. So this I found is extremely important. So there are two studies to substantiate the double gloving and removal of one glove before handling the catheter significantly shown to reduce the risk or alleviate the risk or mitigate the risk of infections with regards to VP sheds or internal ventricular catheters. So this is something simple and it is evidence based and quite interesting for all the intensivists to make note of this. So then we'll move to, so we finished craniotomy, internal ventricular catheters. Now it's about external. So EVDs are most commonly used in ICUs, and this is something where possibly our ICU patients will be at a higher risk for meningitis. So again, as you see, the occurrence of meningitis, the figure is put around 8%, and this comes again from the study from US in 2008. So as you know, there are various type of external ventricular drains. So there is the common ones that are used are external ventricular drain. Then there are the subdural drains and epidural drains and subarachnoid drains. So there are different drains and the parenchymal drains. The commonest one that tends to be used is the ventricular drains, extraventricular drain, and the risk of meningitis is around 8%. And the risk increases when these drains are placed more than 5 days for no reason. But there is one study from China, which was a prospective randomized controlled trial, where they shown routine removal of EVD within 5 days, not necessarily reduce the risk of meningitis. But having said that, if there is no need for the EVD to be present after 5 days, one should possibly consider removal because it does increase the risk after 5 days. And that's what has been shown in the studies. So, and now the question is, what are the risk factors for meningitis when EVD is present? I think any EVD that is present, if there is a local bleed that happens, so if there is any blood in the vicinity of the EVD or hemorrhage, so that any blood becomes an important medium for the growth of bacteria. So the presence of blood at the site of insertion becomes an important risk for meningitis. Or when there is blockage of the EVD drains because of the blood clots or any other reason, becomes an important risk for meningitis. Or frequent CSF sampling from the EVD drain. So you keep sampling the CSF from the drain with an intent to do the testing because you would be opening up to the atmosphere. So the key aspect, which every possibly neurosurgeon would agree, is to keep these drains as a closed system and not manipulate it, not touch it very often, or open it into the environment, because that significantly increases the risk of nosocomial meningitis. So this has been clearly shown even in the studies. And what about, so that was 8%, craniotomy was 1 to 13%. So the highest risk, as you see, was what internal ventricular catheters. What about external lumbar catheters? So external lumbar catheters or lumbar drains are used in treatment of normal pressure hydrocephalus. And the risk, as you see, is put at around 5%. So anyone with normal pressure hydrocephalus undergoing lumbar drain to relieve the symptoms, the risk of nosocomial meningitis is put around 5%. And this again comes from study from US published in Neurosurgery Journal. And the risk factor is, as I said, again, the risk factors are very similar to external ventricular drain. Frequent disconnection of these lumbar drains or manipulating the lumbar drain or opening it to the air or when there is a kink and breach in these lumbar drains or fracture of these lumbar drains. So they constitute important risk of them developing meningitis. And in fact, the evidence suggests that if there is disconnection of these lumbar drains or opening of these lumbar drains with more than 2 times, these drains typically have to be removed permanently and they should not be kept because the risk exponentially increases after subsequent sort of a manipulation or exposure to the air. So disconnection more than 2 times, one should really contemplate that the drain is not of much help and one should possibly consider removal after second disconnection. And this was another study again published by US authors in neurosurgery where they did look at 233 patients who underwent lumbar drains and they found the risk to be even much lower. It's 0.8%. So the risk with possibly lumbar drain is much lower as opposed to internal ventricular catheter, followed by external ventricular catheters, craniotomy, and the last would be the external lumbar catheter as a risk for nosocomial meningitis. And how about lumbar punctures, the spinal anesthesia or any spinal tap or any of these procedures? So the risk is pretty low. As you see, it's 1 in 50,000. So the risk significantly reduces with lumbar puncture procedures, and it significantly increases with any catheters placed within the brain. So that is something which every intensivist can bear in mind. Any drain within the brain constitutes highest sort of a risk, and VP shunts highest risk, followed by external ventricular drain, followed by craniotomy, and last would be anything to do with the spinal canal. So that is something you can keep in mind. And how about head trauma? Head trauma also significantly constitutes an important risk for nosocomial meningitis. And the risk has been put as 1.4%, again published in Neurosurgery Journal by the US authors, Bullock et al. And when there is open compound fracture of the skull in traumatic brain injury, the risk increases to 5%. And it increases to 2 to 11%. And 5% of the traumatic brain injury tends to have open comminuted fracture. But when there is basal skull of fracture, the highest risk of nosocomial meningitis will be with the base of skull fracture, where the risk is put at 25%. So if you look into the whole epidemiological pattern, the highest risk would be with the base of skull fracture, followed by BP shunts or internal ventricular catheters, followed by EVD, followed by craniotomy, and the last would be spinal. So this is something you can keep in mind. The reason is the base of skull fracture is in a close proximity, and there is a communication that gets established between the subarachnoid space and the sinuses. And as you see, there is a lot of CSF accumulation within the sinus. As I said, the primordial reason for nosocomial meningitis will be simply due to CSF leak that happens from the dura or the meninges into the sinuses, and that constitutes the highest risk for meningitis. And the median duration that meningitis tends to occur in base of skull fracture is around 11 days. It has been put. And as I said, the communication established between the sinuses constitutes the highest risk for meningitis. And this remains the major reason. And many a times in traumatic brain injury, this becomes unrecognized. Many a times, even in ICU, someone comes with BSO, base of skull fracture. If the GCS goes down with ongoing fever, seldom we may be able to recognize that there is CSF leak that has happened because the sinuses may have hemosinus. We don't know whether that hemosinus also has CSF leakage present. So it's very hard to recognize CSF leak that is concomitantly present with hemosinuses, because very often we see severe traumatic brain injury having hemosinuses, and this hemosinus may also have CSF leak, and it may significantly increase the risk of meningitis. And many a times this CSF leak resolves in 7 days. And another important signs where the risk of meningitis goes up is where there is depressed skull fracture. If the depressed skull fracture is more than 1 centimeter depression, that constitutes the increased risk of them having nosocomial meningitis. And more than 1 centimeter depression possibly mandates surgical intervention as well. So one has to carefully examine for any contamination of these depressed fracture, because this can easily lead to meningitis. And this should be very carefully debrided, because if this is not addressed surgically, neurosurgically, the risk of meningitis increases. And maybe in this case, prophylactic antibiotics, as per the policy of the ICU or protocol, one has to institute. And any traumatic brain injury where there is presence of pneumocephalus also increases the risk of nosocomial meningitis. Or if there is a traumatic brain injury with fracture of the skull with subdural hematoma, all this acts as additional risk for nosocomial meningitis. And this is something which we typically see in ICU. And this whole slide shows the typical patients that we see in ICU: base of skull fracture, subdural hematoma, pneumocephalus, or fracture skull with depression more than 1 centimeter. All this we see. So here more aseptic precautions have to be put in place, and more careful debridement and examination, and having a vigilant consideration about possibility of CSF leak, which may lead to nosocomial meningitis, have to be kept in mind. So that's about the whole epidemiology we spoke. Now we'll slowly move to the pathogens. Although the literature comes from the Western literature predominantly, Staph aureus remains the commonest, but in India, I have to emphasize it can be any of the ICU bugs that can lead to nosocomial meningitis because of the infection control practices, the staffing, and the handling of these neurosurgical patients. So the typical pathogens where pictorially I put, so these are the Staph aureus looks. So Staph aureus remains the commonest, but if there is basal skull of fracture with communication to the sinuses, then it is the Streptococcus pneumonia or beta hemolytic Streptococcus species. And just pictorially I put for all our ICU training, this is how these organisms look. And there is another organism called Propionobacterium acne. So this is how it looks. But in ICU, any of these escape organisms like E. coli, Enterobacter species, Klebsiella, Acinetobacter, Pseudomonas. So this is how the morphology of all these organisms look. Any of these organisms which are prevailing in ICU with no good infection control practices, with these bugs which has colonized the skin, they all can lead to nosocomial meningitis, and it can be polymicrobial. So please bear in mind, in Indian ICU, any of these escape organisms are the cause, but the commonest one reported in literature will always be gram positive. It will be Staph aureus or Staph epidermidis also is very common. And there is this other one which intensivists can remember, Propionobacterium acne. So that is also one of the commonest one that is reported. So now we look into clinical findings and diagnosis, and most of you listening to this would know that it will be very non-specific. Nosocomial meningitis, you don't see typically presenting with meningeal signs and stuff like that. So they would have temperature, low-grade temperature or temperature spikes. But the key aspect would be any deterioration of the GCS. Suppose patient with TBI has had a progressively improving GCS and suddenly the GCS goes down with worsening temperature. So one should always have in mind there is a potential of them having a risk of nosocomial meningitis, more so when there are EVD drains in place. And meningitis signs is shown to occur in less than 50%. And obviously, when the GCS goes down, the first thing that you would do is a imaging of some sort, CT scan, to see whether there is worsening of brain edema, worsening of hemorrhage, or whether there is bleeding at the EVD site. All these are indicators that possibly there is a risk of nosocomial meningitis that may be happening. And CSF analysis remains the gold standard to establish the diagnosis of meningitis. So in CSF, this is something I want the intensivists to bear in mind. So we can't rely too much on total count and differential count. Gram stain and culture has shown to have increased specificity but low sensitivity. TC, and biochemistry can be used as an adjunct because if sugar is low, obviously you know there is meningitis. But total count it can be notoriously misleading because of the serum that may be admixed with the CSF, and those calculations of 500 RBCs to 1 WBC, all those have shown to be erroneous. So we can rely on gram stain. Biochemistry, low sugar is something that you can look out for. If there is low sugar, obviously it indicates there is meningitis, and that you can correlate to your blood glucose level as well. And blood cultures. So these are the standard tests anyway, in any place, any intensivist would do. But CSF analysis is something you should keep in mind high up in the list, especially when GCS goes down and you're contemplating the possibility of nosocomial meningitis. But in CSF, there are other adjunctive tests which has come in the forefront, which you could possibly do. And those are CSF, CRP, and procalcitonin. So there is another thing. If someone has a VP shunt, then there can be peritonitis also. in the distal part. So you have to look for these peritoneal signs also that may indicate to you that there is possibly nosocomial meningitis. So which means they have VP shunt and they may present with abdominal symptoms, or they may have signs of peritoneal irritation. That is something one needs to keep in mind. And this is studied to indicate to you how cell counts can be misleading. So this was a study that came way back in 84, where they looked at 172 patients with EVD drains, where culture sensitive was positive in 22%, but where cell counts were normal in 4 out of 18, which means to say cell counts not necessarily correlate with culture positive meningitis. And this was the study to indicate, although it's a old study. And this was another study from France, where they showed many a times they may have culture negative and it will be due to aseptic meningitis. Aseptic meningitis is where the blood RBCs lies and they cause irritation in the meningitis, which leads to ventriculitis, where there is no infection, but there are inflammatory cells. So which not necessarily will need antibiotics to treat this. So all this goes on to indicate, so looking at the cell counts, not necessarily will tell you whether there is a nosocomial meningitis, but rather you can look at other adjuncts like CSF lactate. So this was a study. I'm sure most intensivists would be practicing this, and we do this routinely in my ICU. I tell all my trainees, please do CSF lactate, which is the simplest thing. Take the CSF, put it in the blood gas machine, you'll get a lactate. And CSF, if CSF lactate is more than 4 in patients where you're suspecting there is meningitis, it does indicate that possibly he has meningitis, because if you look at the sensitivity, it's 88%. This was a study which came from Switzerland. Specificity was very good, 98%, and even positive predictive value was 96%, and negative predictive value is 9. So which means CSF lactate is something that can be relied more than the cell count. So you can do gram stain, which will tell you it is possibly meningitis. You can look at biochemistry, but don't pay too much attention to TCDC. Rather look at lactate. That gives a better indicator, because TCDC can go up even in aseptic meningitis, and that's what the studies have shown. The other test one could look at is, you can look at CSF procalcitonin. This is making some sort of a news, and possibly we should do more studies in India as well, and CSF PCR. So these two tests are here to stay. CSF CRP can be quite non-specific, but we look into what are the studies with regards to procalcitonin. So this was a study that came from China, where they looked at 50 patients, where they looked at CSF procalcitonin, and they compared between post-neurosurgical bacterial meningitis and non-post-neurosurgical bacterial. So they had proven bacterial meningitis and non-bacterial meningitis, and they found that CSF prolactin significantly went up in patients who had bacterial meningitis post-neurosurgical, and it was statistically significant. And possibly every intensivist listener should know what is the cutoff value. In this study, the cutoff level for procalcitonin was more than 0.075 nanograms per ml. And they looked at sensitivity for this, it was 68%, and specificity was 73%. But the same authors, when you combine CSF procalcitonin with CSF lactate, then the sensitivity came down, but specificity significantly improved to 91. So the take home is, obviously the easiest thing is you can do CSF lactate. If it's more than 4, it proves meningitis. If you're not sure, you combine it with procalcitonin. If procalcitonin, CSF, because most ICUs would be doing procal. So send for CSF procal. If it is more than 0.075, along with CSF lactate may be high, it can definitely possibly indicate to you that he has meningitis, and you may have to treat accordingly. So these are some of the tests that intensivists can bear in mind. And PCR is also evolving, and we have started doing CSF PCR. And there is some data for this. Again, this data comes from US authors in neurosurgery. They looked at 86 patients where CSF cultures were negative, but PCR was positive. But where culture was negative, PCR also was negative, which means there is a good correlation of PCR with the CSF, with meningitis and CSF cultures. So PCR is also something that we should be adopting more and more. So the take home for the diagnosis is, look at the CSF gram stain, which has to be done. Look at the CSF biochemistry. Then most importantly, the simplest thing is do a CSF lactate. If that is also not helping, adopt PCR and maybe procalcitonin. And this is something that you could keep in mind to establish the diagnosis of neurosurgical meningitis. Okay, so that's about the diagnosis. So hope we are clear with the diagnostic aspect. Now we'll move to antimicrobial therapy. So antimicrobial therapy will go based on the pathogenesis. So if it is a post-surgical, I think this slide would essentially tell you the same message across all causes of nosocomial meningitis. If it is post-surgical meningitis, you need to put an antibiotic which covers obviously staph, which means it has to cover MRSA also, and it has to cover escape organisms and pseudomonas. So the suggested antimicrobial therapy always should be combination with vancomycin with fourth generation cephalosporins, which is cefepime or ceftazidime, which is third generation, or meropenem. So any of these combinations you can consider. If it is a EVD drain, external ventricular drain, again, the causative organisms, as you know, are staph aureus. It can be MRSA, it can be coagulase cons, coagulase negative staphylococcus, or you have to keep this other organism, propionobacterium, or escape organisms. Again, the choice of antibiotic will have to be in combination with vancomycin and antibiotics which cover escape organisms. In India, the commonest one would be using meropenem. And if it is a traumatic brain injury, then staph epidermidis, so this is how epidermidis look, or escape organism, again the choice. If you see, for all these three conditions, the choice of antibiotics are the same. And the organisms also pretty much remain the same, except in base of skull fracture, because as I said, base of skull fractures, there is CSF communication to the sinuses. That's where you have to cover more of strep pneumonia or beta hemolytic streptococcus and Haemophilus influenza also. There, the suggestion is you can use lesser antibiotic like vancomycin with ceftriaxone or cefotaxime to mainly cover strep pneumonia species. And even vancomycin would cover. So this is the sort of suggested antimicrobial therapy. And it is also suggested if all your diagnostic tools do not indicate that there is no meningitis, then antibiotics have to be stopped after 72 hours if there is no evidence, if there is no established diagnosis of meningitis. And when using vancomycin, it is recommended that the trowel concentration, so TDI, therapeutic drug concentration, has to be assessed, and serum trowel concentration has to be monitored. So therapeutic drug monitoring of some sort has to happen at 15 to 20 micrograms per ml. And if vancomycin for some reason cannot be used, the other choices are linezolid and daptomycin, but your first choice would be vancomycin. So this is in brief about the treatment guideline or treatment suggestion that one should adopt for any of these nosocomial meningitis. So now the question remains, how about intrathecal? So for intrathecal antibiotic, there's no FDA approval. I'm sure most of the listeners know that the intrathecal colistin that we give or any other, there's no FDA, but this is something one could consider, and there is some body of evidence for this. And when intrathecal antibiotic has to be administered, the EVD drain that is present could be used to give this antibiotic, to administer this antibiotic. After the antibiotic is administered through the drain that may be present, the drain has to be closed for 1 hour before it is opened for drainage. So the different antibiotics that can be used intrathecally is vancomycin. The dose is 5 to 20 milligram. So this is something which intensivists can use as a ready reckoner. It's a smaller dose that we use for intrathecal. Gentamicin is 4 to 8 milligram. Amikacin is 5 to 50 milligram. Colistin is something that we have also used, and we have also published our study in the journal. So I will show you that. So colistin is 10 milligram, is something that can be used intrathecally, mainly for our ICU sort of bugs in India, typically where we deal with CRE, carbapenem resistant enterobacteriaceae. Even polymyxin can be used. It is used at a dose of 5 milligram. So these are the dosages for intrathecal administration of antibiotics. And now the question is, how do we ascertain that these are the dosages that are proven to be effective? For that, the suggestion is you have to establish good CSF concentration of these antibiotics. And one of the ways to establish good CSF is to look at trough concentration divided by minimum inhibitory concentration. It should be more than 10 to 20. And if it is more than 10 to 20, scientifically, you could establish that your CSF level of this blood is good enough to achieve good sterility of infection that may be present. So this is the sort of recommendation that has been given. And this was another study from Greece where they looked at 14 patients with Acinetobacter, where they're given IV plus intrathecal, and they established 100% cure. Okay, so then we'll come to the last bit, which is removal of catheters. So obviously, when someone has a EVD drain or a VP shunt, then the question remains, should the catheter be removed? So the answer is very easy. Obviously, when you have a foreign body and you have a meningitis, then the ideal situation would be that catheter, internal ventricular catheter or EVD, has to be removed. So if there is a VP shunt that is infected, then the recommendation is the VP shunt has to come out, and someone needs a shunt, then external ventricular drain has to be put. And it is shown that success rate is around 85% with this sort of a strategy. And this external ventricular drain, once it is put after someone has had a meningitis, should be utilized for CSF monitoring. And it is also shown to resolve your ventriculitis. And this situation typically happens in patients with normal pressure hydrocephalus or obstructive hydrocephalus where a VP shunt. Obviously, you remove VP shunt, so his hydrocephalus would worsen. So you have to put a EVD, and until your ventriculitis resolves and your meningitis has resolved, and success rate has shown to be 85%. And the duration of antibiotics for typical organisms like cons or Propionibacterium acne is around 7 days, even when there is a device-related infection. So the duration of antibiotics is for 7 days. After administration of antibiotics for 7 days, CSF culture has to be negative sequentially up to 10 days, before which another drain could be put in. So it's not like we give antibiotics for 7 days and put a drain again. So we have to prove that cultures have been negative for at least 10 days before a new drain has to be put in or is thought of put in. So these are some of the studies. So this again was a study which they looked at EVD removal plus intravenous antibiotic, established a cure rate of 65%. But EVD, keeping EVD, suppose you cannot remove EVD, administration of only IV antibiotics and intrathecal antibiotics has shown to reduce the cure rate to 35%, which means the safest way to deal with this is to remove the catheter. But for some reason, you have to keep the catheter, then obviously you have to give long-term antibiotics with intrathecal antibiotics. So this was another study from Spain in 43 patients where they removed the catheter, used a combination of IV antibiotics and intrathecal. They established a cure rate of 84% in Staph aureus. In non-Staph aureus, they established a cure rate of 92%. So the gospel is the drain has to come out, because if you keep the drain, the cure rates come down to 34%. By keeping the drain, giving IV antibiotics and even adding intrathecal enhances your cure rate. So that's about, so basically in this whole talk, as you see, nosocomial meningitis, we covered the epidemiology. So the take home is the epidemiology, the highest sort of the infection rate happens in base of skull fractures, followed by internal ventricular catheter, followed by EVD, followed by craniotomy, and followed by the spinal. After this, we looked at the organisms. Organisms are pretty much the Staph aureus, and if it's base of skull, you have to have strep pneumonia, Propionibacterium, and all the escape organisms typically that happens in our country. With diagnosis, it is mainly gram stain, culture, CSF lactate is here to stay, easiest, and you can add procalcitonin and PCR to be adopted more to establish the diagnosis of meningitis. Treatment, as you saw, it is only vancomycin with 3rd generation or 4th generation cephalosporin or carbapenem, and catheter has to be removed. So that is about the summary of this whole talk. So thank you one and all. And the recurrence rate, as you see, is 26%, and 1/3 is found to happen with same organism. And this is the study that we published where we used CSF lactate as a prognostic marker, and we used intrathecal colistin, and we published sometime in 2010 in one of the journals. So thank you one and all. So end with this beautiful quote: the moment we refuse to hurt others because of our own pain is the time we evolve as souls. So thank you one and all. You can visit my website www.drpradeepnagaba.com to rehear to this lecture. Thank you one and all.